Good evening, everyone. We welcome you all to OrthoTV online. This is the part one of the postgraduate teaching series from OrthoTV. And with this, I hand over to the coordinator of this series, which is based on spine topics, to Dr. Rohan Gala, who is an assistant professor in D.Y. Patil Medical College and a consultant spine surgeon. And Rohan Gala will go ahead and introduce the speaker to you today. Thank you.
Thank you again. May I introduce to you Professor Tarun Suri. He's an associate professor from Maulana Azad Medical College and a consultant spine surgeon. He did his FNB spine surgery from Park Clinic from the Department of Neurosciences. And these lectures are going to be the weekly lectures, which are going to be basically targeting the pathophysiology and the investigative part, and the other half would be the management. So I think Dr. Suri is going to today talk about the etiopathogenesis and the clinical presentation. And next week, he's going to talk on management. So this is going to be an interactive session where the residents, if you have any doubts during the lecture or even after the lecture, you all can always ask your questions. And over to Dr. Tarun. So.
Yeah. Good evening, Dr. Rohan and Dr. Neeraj. Thank you to your team and to OrthoTV for starting this wonderful series where postgraduates can be introduced to the spine topics which are often confusing for them. So we will start the series by with this first topic, spondylolisthesis. Is my screen visible?
Yes.
Yeah. So spondylolisthesis, as we can all understand, it is made up of two Greek words, spondylo and olisthesis. Means a slip of spine or vertebra in relation to another vertebra. So it can be ventral or dorsal displacement. Most commonly, we see ventral displacement, which is called as anterolisthesis. And sometimes we also come across dorsal displacement of one vertebra over the other, which is called as retrolisthesis. So what happens, why does the spondylolisthesis develop? There are various etiologies and mechanisms, but we can all understand that our body is in a dynamic position in relation to the gravity and the various muscle forces acting, and so is spine. The majority of forces acting on the spine are the caudal vector by the gravity and a ventral vector by the muscle forces. And this caudal ventral vector is a very strong vector, but in a normal spine, it is countered by the intact mechanisms which are formed by the intervertebral disc, the facet joints, the posterior arch, and the pedicles. So if there is any failure in these mechanisms, it can lead to spondylolisthesis, where the caudal and ventral vector by the gravity and the muscle forces, they take the vertebra caudally. So what is the effect of this displacement or listhesis on the patient and the body? So as we can understand, as the vertebra shifts forward, it carries with the cephalad levels of spine with it. And this can lead to pathological spine malalignment, which can be an important and cause of significant axial back pain. It can also cause symptoms of spinal stenosis because the nerve roots get stretched and the various foramina, they get filled with the secondary changes occurring in the facets and the ligamentum flavum. It can also lead to compensatory changes in other region of the spine, because we all know that spine, different regions are linked to each other. So it is not just the lumbar spine which gets affected, but in the long term, it can lead to compensatory changes in the thoracic spine, in the cervical spine as well. So these patients in the long term can complain of upper back pain, mid back pain, or even the neck pain. And it can also lead to compensatory changes in the pelvis and the lower extremities. In severe cases, there is so much disruption of the sagittal balance that there can be significant positive global sagittal balance, which can lead to significant back pain and energy consumption of the body with impairment of the quality of life. Now, what are the clinical features of spondylolisthesis? Now, clinical features are mostly similar to lumbar canal stenosis, and we should also understand that in many cases, the spondylolisthesis may just be a radiological diagnosis and the patient may be totally asymptomatic. So it is important to treat the patient and not the X-rays, and clinical evaluation therefore is paramount importance in deciding the management. The patient most commonly has low back pain with or without leg pain. Low back pain is the most dominant symptom of spondylolisthesis, and leg pain is present in most of the cases, but in some cases it may be absent, especially in initial cases. So back pain with spondylolisthesis, it is typically mechanical. So this thing, I think as residents, we all should understand what is a mechanical kind of back pain, because it is very important to elicit this history. The mechanical back pain is a pain which occurs because of instability, when two different parts of the spine or vertebrae, which should normally stabilize the spine, the mechanism is defective. The patient changes the posture. He will experience a lot of pain in the postural change. For example, the patient will complain that on turning and taking turns in the bed, they have increase in the back pain. While changing posture from supine to sitting position, the pain increases. On arching backwards, they have an increase in pain. So these are all indicators that the pain is occurring when there is some change in the posture and indicates an instability or a mechanical pain. This back pain is usually aggravated by back extension or arising from a bent posture, and it is to be distinguished from discogenic back pain, which is typically provoked by flexion or sitting. So back pain because of spondylolisthesis is usually exacerbated when the patient hyperextends or extends the spine, in contrast to a discogenic back pain or pain caused by a prolapsed intervertebral disc, which is usually caused by flexion of the spine or bending forwards. The leg pain which occurs in spondylolisthesis is usually of two types. It can be a radicular pain or a neurogenic claudication. What is neurogenic claudication and how it is different from radicular pain? Let's understand this. Now, neurogenic claudication is a diffuse sensation, most commonly appreciated as pain, but can also be appreciated as paresthesias, heaviness, or weakness, which occurs only with walking or standing. Okay, so the symptoms are typically produced by standing or walking and are relieved by sitting or bending forward. And some patients may preferentially assume the stooped over posture when walking or standing to get relief of the symptoms, which is often called as grossly cart sign. Neurogenic claudication is often bilateral and it has less dermatomal distribution and is a diffuse non-dermatomal kind of pain. On the other hand, radicular pain is typically dermatomal. It extends in one particular dermatome which is getting affected and is usually unilateral. And it is often seen with lateral stenosis, foraminal stenosis, or an associated disc herniation with spondylolisthesis. Now, coming to the various grading systems for spondylolisthesis, the most commonly used grading system for spondylolisthesis is called as Myerding grading. Now, what is Myerding grading and how do we calculate that? First of all, we calculate A. A is the amount of sacral end plate which gets uncovered after the slip. And we measure B, and B is the total width of the end plate. So you measure these two values and see how much percentage of the end plate is getting covered, and that is the percentage of slip which gives us a grade. So what are the grades? So grade 1 is typically 0 to 25% slip. Grade 2 is 25 to 50% slip. Grade 3 is 50 to 75%. Grade 4 slips are between 75 to 100%. And grade 5, which is also called as sometimes spondyloptosis, occurs when the L5 end plate is completely falls ahead of the sacral body. So grade 1, grade 2 slips are often called as low-grade spondylolisthesis, while grade 3, grade 4, grade 5 are termed as high-grade listhesis. Coming to the classification of spondylolisthesis, now classification was initially described by a group of workers called as Gilsey, Newman, and McNabb. So they have the most popular etiological classification, and they have classified 5 types of spondylolisthesis, in which the first one is dysplastic type. Now, what is dysplastic? In dysplastic, as you can see in the figure in the circle, there is some deficiency of the L5 S1 facet joint, and therefore that linkage is loose, and that causes the L5 to slip over S1. The second variety is isthmic variety. Now, isthmus is the pars interarticularis region, and there is some lesion in the pars interarticularis, but the facets are normal, and any defect in the pars is therefore called as isthmic spondylolisthesis. Now, here I would just like to go to anatomy and clear some doubts which I often see that residents have. They fail to understand or what part of the bone is pars interarticularis. So as we can see in this 3D model, this is the model of the lumbar spine. So this is the vertebral body. This is the vertebral body. This is the pedicle. So as we go back, we see that each vertebra has, for example, let's see L5 vertebra. It has a superior facet and it has an inferior facet. Now these facets are forming joints with the facets of the adjacent bone. For example, this is S1. So this is superior facet of S1 and this is L4. This is inferior facet of L4. So these two are the facet joints. This is the L4-5 facet joint and this is the L5-S1 facet joint. So between two joints, this pillar of bone is called as pars interarticularis. Since it is between two joints, the term uses interarticularis. Okay, so this is the area which is called as a pars and or the isthmus, and this is the area where the problem in type 2 spondylolisthesis according to Wilsey classification is occurring. So going back to the classification system. So we have the isthmic type where the problem is in the pars. In this, we can have 3 subtypes, which we will discuss later on in the talk. The type 3 is degenerative type. Now, degenerative type is the most common, where there is degeneration of the disc space, which leads to secondary arthropathy of the posterior facet joints, hypertrophy of the ligamentum flavum, and the whole mechanism between two vertebrae, it gets loose and the slip occurs. So that is called as degenerative spondylolisthesis. The fourth variety is traumatic type, but the traumatic type, type 4, is different from type 2 in the sense that it is without a pars fracture. So when there is a fracture dislocation of the lumbar joint, it is termed as a traumatic variety of spondylolisthesis. And type 5 is a pathological type where the slippage occurs because of some sort of pathology such as infective pathology, neoplastic, metastatic pathology, which can also lead to spondylolisthesis. So these are the 5 types, and we usually remember them by the term DID TP, DID TP. So D is for dysplastic, I is for isthmic, degenerative, traumatic, and pathological. So coming to each variety one by one, the first one is dysplastic spondylolisthesis. So as we discussed, L5-S1 facet joint is a very important linkage between L5 and S1, and if there is any deficiency in this hook mechanism, it can lead to forward slip. So and it can also often lead to high grade listhesis. Now you can see in this X-ray that these parallel lines which I have drawn are the normal facet joints between the lumbar vertebrae. But if you look at closely at L5 and S1, there is some slippage of L5 over the S1. And if you look at the joint closely, this joint is dysplastic or not normally oriented as compared to the other proximal joints. So this is a dysplastic kind of spondylolisthesis. Okay, so have a look at again the normal orientation of the facet joints and a dysplastic facet joint. The next variety is the isthmic spondylolisthesis, where I showed you where is the isthmus, what is pars interarticularis, and there is a defect in the that part of the vertebra. So it can be of 3 types. A type 2A is a lytic variety or lytic spondylolisthesis, where there is a fatigue fracture of the pars. So because of stresses in the lumbar spine, pars region, it keeps on getting traumatized, and slowly the stress fracture develops there and can lead to a pseudoarthrosis or a fatigue fracture, which is termed as a lytic spondylolisthesis. Now in type B, the pars is developmentally not formed normally. It's a very elongated pars as compared to a normal strong pillar of bone, and that can lead to a type 2B kind of spondylolisthesis.
So may I interrupt you? The screen has frozen. Poonam, can you look into the screen? Or whoever is there. Poonam, are you there?
Yes, sir.
The screen has frozen. I just got a text from one of the one of the residents on the meeting, and he's like, the screen has frozen.
Just change the slides.
Others can confirm whether the
Yeah. So Himanshu is saying that the screen's working. So you may go ahead. Yeah.
is it working?
Yes,
Yeah.
we can see.
Okay. Sorry, sir. Sorry to interrupt. You can continue.
No problem. So in ischemic variety, we have discussed type 2A and 2B. 2A is a lytic variety where there is a stress fracture of the parts. 2B is a type where there is elongated parts. And type 3 is acute traumatic fracture of parts. Now, if you recall the previous slide, the type 4 was traumatic listhesis. Traumatic listhesis type 4 is different from type 2C here, because if there is only fracture of the parts, it is type 2C. But if there is a fracture of the facets, which leads to a dislocation or traumatic listhesis, that is termed as type 4. So let's look at few images in the X-rays. Type 2 is a lytic variety where you can see there is a fracture or defect in the parts. You can see here, and you can see an X-ray here where there is L5 S1 listhesis. There is a slip of L5 over S1, and this is a normal pars, and there is a pars defect here. Okay. So this is a type 2A or lytic variety of listhesis. In type 2, we have a elongated pars where the shape of pars is abnormal. It is more elongated. So this is a normal pars. You can see L4. This is fine. But look at the pars of L5. It is elongated like this. So you can appreciate in this X-ray, this is a normal pars here, while L5 has an elongated pars. Okay, so this is type 2B kind of ischemic spondylolisthesis. Now type 2C is a acute traumatic fracture of the pars, and it is a very, very rare entity and very difficult to diagnose on the routine X-rays. In fact, a CT scan and sometimes on oblique views may be required to document these kind of injuries. So coming to the next variety, traumatic spondylolisthesis. So in traumatic spondylolisthesis, which was type 4, there is no fracture of the parts, but there is fracture of usually the facets or the pedicles. And these kind of injuries cannot be caused by very trivial trauma. These are very, very high energy trauma, which can disrupt the strong facet joints. For example, you can see in this X-ray that there is a very small degree of slip. If you closely observe, the L5 posterior border is, there is a grade 1 slip over the S1 after a high energy trauma. So this is a CT scan of the same patient. Now, if you look closely, this is the L4. So this is the L4 vertebra. And if you look at the L4 vertebra and the L5 vertebra, the facet joint between them are normal. Normally, the facet of L5, the superior vertebra, is behind the vertebra facet of the L5 vertebra. But if you look at the L5 S1, what is happening? The facet of L5 or the superior vertebra has jumped over the facet of the S1 because of the trauma. Okay. So this is a traumatic spondylolisthesis because of a facetal dislocation. Coming to the next type, which is degenerative of type 3 spondylolisthesis. It is the most common type of spondylolisthesis, and the most common level where it occurs is L4, L5. Now, how does it occur? With the aging process, the intervertebral disc, it loses its hydration and collagen content, and there is degeneration of the disc space, which leads to long-standing intersegmental instability, means instability between two segments of the spine. And because of this constant stresses, they get passed on to the posterior elements, most importantly, the facet joints. And the facet joints slowly start moving more as compared to a normal spine, and slowly they get remodeled and osteophytes, they start developing. They also change their shape and they become more sagittal, and one side starts rotating more than the other. So if you look at the axial CT section, which is shown here, you can see that one side facet joint is in a different plane as compared to the other joint. This is called as Facet Tropism. And when this Facet Tropism develops, the locking mechanism which the facets provide, normal facets provide to prevent the slippage, it fails and a slip develops, which is degenerative spondylolisthesis. So this is how a X-ray of degenerative spondylolisthesis looks like. There is a grade 1 slip of L5 over S1. And if you see the MRI, you can see that there is extensive amount of disc degeneration here at L4-5 level. There is facetal arthropathy. The facet joints are very much arthritic. There is disc prolapse and the ligamentum flavum is hypertrophy. Okay, so this is how a degenerative spondylolisthesis looks like. Now, degenerative spondylolisthesis, they usually slip only up to grade 1 or maximum grade 2 because the facet joints are intact, although they get oriented in different directions, but some amount of stability is provided by the osteophyte formations which occur because of degeneration. So some sort of stability is there. It is not as unstable as a lighting variety, but there is a complete disruption of linkage between superior and the inferior vertebra. So therefore, the degenerative spondylolisthesis, they usually slip up to grade 1 or grade 2, unlike the isthmic variety or dysplastic variety, where they can go to high grades, grade 3 and grade 4. The last variety is the pathological spondylolisthesis, which can occur because of various pathologies such as tuberculosis, pyogenic infections, metastatic infiltration of the spine. So, for example, you can see a tubercular spondylodiscitis here, where there is a retrolisthesis of L4 over L5 because of disruption of the mechanism because of the disease process. Okay, so these are the 5 types, broad 5 types of spondylolisthesis described based on their etiology and mechanisms by Wilsey classification. The Wilsey classification is a very, very useful classification to understand where the pathology is occurring, because each of them behaves differently. But there are certain limitations of Wilsey's classification. First of all, although it gives us the etiology and the exact and the pathological site, but it becomes difficult to predict the progression of each type and how they will respond to surgery. Means it is very difficult to predict whether degenerative will progress more, isthmic will progress more. So it becomes difficult and a limitation of Wilsey's classification. And sometimes there are certain kind of listhesis where which fall in both the kind of two categories, and it is difficult to precisely label it into one category. For example, if you look at this X-ray closely, there is a good amount of grade 3 slip of L5 over S1. It is nearly toppled, the L5 body is toppled over S1. But if you try to fit in it in Wilsey classification, you see here that the pars is very much elongated. So it falls in type 2 variety. But if you look at the L5 S1 joint, that is also dysplastic. So it is very much difficult to differentiate whether it is type 1 or type 2. So that's why because of this limitation of the Wilsey classification, further classification systems were developed. So next came the Marchetti and the Bartolozzi classification, where the groups were based on their behavior and their prognosis. And a system was developed where we are able to predict the behavior of the slip by identifying whether it is a low grade slip versus a high grade slip. So essentially what they did was, the most important confusion was between the dysplastic and the isthmic, just like we saw in the previous X-ray. So they combined dysplastic and isthmic into one group. Okay, and the system which they developed was, this looks very confusing, but to remember easily, they broadly divided 2 types of listhesis: developmental or acquired. Now, acquired can be because of trauma, it can be because of surgery, it can be because of pathology, or it can be because of degeneration. While developmental, the reasons are because of either dysplasia, inherent dysplasia, or because of some sort of isthmic problems. So they combined the isthmic and the dysplastic into developmental category. And they divided this dysplastic variety into high dysplastic and low dysplastic variety to understand and predict whether they will progress or they will progress slowly. So let's understand how do we identify a high dysplastic variety versus a low dysplastic variety. And why do we need to do that? Because if a patient presents you with symptoms and such kind of X-ray, you can counsel them that one patient has a high dysplastic listhesis, and so he will progress rapidly and has more chances of failure of conservative management, while a low dysplastic, which may respond well to a conservative management. So let's look at the features of high dysplastic variety. In high dysplastic, you can see here the S1 sacral end plate has become dome shaped. The L5 body has become trapezoidal. There is significant amount of lumbosacral kyphosis. The L5 S1 disc space, which is normally lordotic, has become kyphotic here. The next feature is an elongated or interrupted pars. And there is a compensatory hyperlordosis of the lumbar spine, and the sacrum has become vertical shaped. So these all are features of high dysplastic spondylolisthesis. Let's just revise them once again. A dome-shaped sacrum end plate, trapezoidal L5 body, profound lumbosacral kyphosis, elongated pars, and a vertical sacrum. In contrast, let's look at the features of low dysplastic variety. This is a low dysplastic listhesis. You can see that sacral end plate is preserved. It's straight and has not become dome shaped. The L5 body has its normal rectangular shape preserved. There is minimum lumbosacral kyphosis, and these features, low dysplastic variety, they have less risk of progression as compared to a high dysplastic kind of listhesis. So this is where the Marchetti and Bartolozzi classification, it takes an edge over Wilsey classification, because it tells us that the listhesis with high dysplastic features has a higher degree of progression and resulting in a failure of conservative management. Okay, so to revise, we had the myodine grading system, which divided the which told us about the amount of slip, quantified the slip, where you have grade 1 to grade 5, the grade 1 and grade 2 being the low grade, and above that being the high grade slips. Then you had the Wilsey classification, which divided the listhesis into dysplastic, ischemic, degenerative, traumatic, and pathological. And lastly, the Marchetti-Bartolozzi type, which divided the listhesis into developmental versus acquired, and developmental can be a low grade or a low dysplastic or a high dysplastic. Okay. So these were the important classification systems and grading systems, which as postgraduate students, we expect you to know and to identify with among the patients presenting to us in the OPD. Now, there is a group called as Spine Deformity Study Group. Spine Deformity Study Group in early 2000, they found out that there are certain pelvic parameters and sacral parameters which have an effect on the alignment of the lumbar spine and of the whole spine, which can affect the quality of life of the patient. So they defined 3 parameters, most importantly, the pelvic incidence, and they tried to establish a classification system based on whether a pelvis has a low PI value or a high PI value. Okay, so the divided 3 parameters, namely the pelvic incidence, a pelvic tilt, and the sacral slope. And they also studied the relation of these parameters in relation to the sagittal balance. Now, how do you look for sagittal balance? And a sagittal balance is looked at in a whole spine standing lateral view, where you draw a C7 plumb line from the center of the C7 body, which a vertical line going downwards, and it intersects the posterior superior corner of the S1 vertebral body. This is how the normal sagittal balance of a normal spine looks like, and any progression of this plumb line anteriorly towards in front of the sacrum leads to what is called as a positive sagittal balance. So depending upon what is the PI value of a particular pelvis, you can have a pelvis with low PI or a high PI. A pelvic incidence which is low in a pelvis means there are less shear forces acting at the lumbosacral junction, and there is less risk of progression. While if you see the lower picture, the second pelvis which is shown here, now this is a pelvis with high pelvic incidence, this angle, and there is a large slope of the sacrum, and it can lead to a higher shear forces at the lumbosacral junction and a high risk of progression. So with these indices, if you measure pelvic incidence, you can also predict that what kind of behavior that listhesis is going to show. If a pelvis with high PI comes to you with listhesis, then there is a higher chance of progression, and you have to be very careful in treating that patient conservatively and treat before it goes to a very high degree of slip. Okay. So a balanced pelvis is a pelvis in which the sacrum maintains its normal orientation to the spine, and the plumb line, the C7 plumb line is falling at its normal place. Now, when the spondylolisthesis starts progressing, we can all understand the whole spine starts getting shifted anteriorly as compared to the sacrum. And slowly the C7 plumb line, as you can see here, it is not falling on the sacrum, but way anterior to the greater trochanter also. Okay, so in this high-grade listhesis, the spine has become unbalanced. So in order to restore the balance of the body and the spine, the pelvis undergoes certain compensatory mechanisms. And how does it restore the sacral balance? What it does, the pelvis rotates vertically. The sacrum has become vertical, and the spinal balance comes back to its acceptable position. Okay, so by this compensatory mechanism, the sacrum becomes vertical. And this is also called as a retroverted pelvis, where the pelvis has become retroverted so that the high-grade spondylolisthesis, which is causing a global sagittal imbalance, that can be prevented. Now, why body tries to compensate so much for positive sagittal balance? The sagittal balance is something which is very poorly tolerated by our body. Now, there was a landmark study done by Glassman and Bridwell, where they reviewed 350 plus patients with positive sagittal balance, and they found out that the back pain and symptoms which are impairing the quality of life of the patient, they become more severe as the positive sagittal balance increases. So they found out that the sagittal balance has to be within acceptable limits for the patient to lead a good quality of life. With this kind of sagittal balance developing, I showed you that one mechanism by which compensation can occur is at the pelvis. But as the disease progresses, certain other compensatory mechanisms can also start working, and different regions, other regions of the spine and body, they can also start getting affected. For example, the upper lumbar segments can develop retrolisthesis, thoracic kyphosis gets reduced, the cervical spine becomes hyperlordotic, which can lead to neck pain and impingement of the cervical nerve roots. Changes also develop in the pelvis, knee flexion, and ankle joints. So because of these compensatory mechanisms, the body will try to restore the positive balance, but the other parts of the spine and different joints in the lower limb, they will start getting pains and degeneration earlier as compared to the normal person. So with this kind of background, this essentially was the area which I wanted to cover in today's talk. And with this now, we now have few cases where I think I would like to bring in the moderator and the residents, where we will discuss what kind of listhesis we are seeing, what classification do they fit in, and how we can predict their behavior. So this is the first case where we have a 56-year-old male with low back pain, with leg radiation and neurogenic claudication, with significant affection of the activities of daily living, with a mild DHL weakness. So can we have any volunteer who can comment on these x-rays? What is a positive finding?
So who do we have here? Tarun, would you like to start? Or even Varun?
Yes, sir.
Okay.
So this is a plain radiograph of the lateral LS lumbosacral spine. We can see that there is anterolisthesis at L4, L5.
Good.
So I cannot appreciate any Pass defect or lengthening of the parts. On flexion extension view, sir, sorry, sir. So on flexion extension view, we can see that the defect does not get exaggerated per se, then it already is. Sir, I think that I would classify this in Wilson type degenerative.
Okay. So very good, Tarini. I would just like to add few things which can also be seen here. So as she very correctly said, this is a degenerative listhesis. Now, what are the features of degenerative listhesis here? First of all, Tarini, can you tell me what grade of slip is it?
Sir, grade 1.
Okay, good. So this is a grade 1 degenerative spondylolisthesis. As she mentioned, the pars is intact. There is no defect in the pars.
Yes.
So there is no defect in the pars. There is a grade 1 slip. And on flexion extension view, on flexion extension view, if you look closely, the disc space is changing on flexion and extension. That means there is some degree of instability which is occurring. It is opening more on extension and closing on flexion. So there is some degree of instability. There is grade 1 slip. And what I would like you to appreciate is, if you look at the AP view, look at the facet joints. This is a facet joint on the AP view. So on one side it is oriented like this. On the other side, it has become almost horizontal. So this is tropism, and these are associated osteophytes. So these further indicate that we are dealing with most likely a degenerative spondylolisthesis. Okay, so this was the MRI of the patient, which showed a significant amount of disc degeneration, facetal joint arthropathy, and ligamentum flavum hypertrophy. Okay, so going on to the next case. So this is another case, a 69-year-old male with similar symptoms. So can we have any other volunteer to comment on what kind of listhesis are we looking at?
Dr. Krishna or maybe Dr. Shankar can help us out here. Okay, is Suraj there? Can Suraj classify this?
Okay, so just to quickly tell you about this. This is a grade 1 spondylolisthesis, which we can all see. There is a grade 1 listhesis of L5 over S1. L4 over L5. And this is also a degenerative spondylolisthesis. It's a grade 1 slip in a very elderly gentleman. There is no defect in the pars. You can see again that there is significant amount of facetal joint degeneration seen at the L4, L5 facet joints on the AP view. Okay, so this is again a case of degenerative spondylolisthesis.
Sir, I have a question. So in the previous X-rays, has this patient has any change in the pelvis? Like you said, the pelvis incident, and has it become more vertical or it's normal?
No, I think that's a very, very good observation. You can see here in this X-ray lateral view that the sacrum is almost vertical. Can you appreciate?
Yes, sir.
So the sacrum has become almost vertical, which indicates that this is a retroverted pelvis. This is occurred because of a compensatory mechanism to restore the positive sagittal balance. Okay, so we move on to the next case now. Yeah, so 64-year-old male with again low back pain with left radiation, some weakness of the left ankle dorsiflexors. Any volunteers for commenting on the L5S1 mild grade 1 listhesis which is there?
Varun is there or Nupam? Somebody? Abhilash? I think they are unable to connect for some strange reason.
Hello?
Yeah, Varun, you're there?
Hi, sir. I'm there, sir. This looks like there's a pass defect of the L5. Yeah. I might be wrong, sir. I don't know.
Oh, Varun, you are correct. Very good observation. This case I have put specifically to highlight that don't just go by the age. So this is a 64-year-old patient, but if you look closely, this is a normal pars. The L4 pars is normal, but look at the L5 pars. There is a break here. Okay, look at this break.
Yes, sir.
There is a pars defect, and this is a grade 1 lytic listhesis. Okay, so age is not a criteria to diagnose which kind of listhesis. You have to look at the various aspects and various areas in the spine to look to decipher what kind of listhesis we are dealing with. So these are the MRI cuts of the same patient, and you can see that there are 3 MRI cuts. The side ones are the parasagittal cuts, and the center one is the MRI mid-sag cut. So if you look at the parasagittal cuts, you will appreciate that there is a small pars defect here. The pars is broken.
Yes, sir.
Similarly here. So that's why this listhesis will be categorized as a lytic kind of listhesis. Okay. So this is another case of 30-year-old male who had a very severe fall from a 20 feet height and presented to us with low back pain and left hemothorax with some weakness in the bilateral gastrosoleus muscles and decreased sensations in S1. And because he had a back pain and some ankle and foot weakness, we got an X-ray of LS spine done. And can somebody tell me what is seen on the X-ray?
So again, who's next now? Prashant, Nupam, Home. Is anybody around? You all can answer this. Nupam, you can go ahead if you want. I mean, can you take this one? Tarani, Suraj, Shashank. Can anybody? I think there's some network issue. Rakesh.
Yes, sir.
Take this one, please.
This X-ray shows there is a anterior listhesis of L5 over S1, sir.
Good.
With an increased disc space between L5 and S1, sir.
Very good. And can you see any fracture?
I can't really appreciate the fracture, sir.
Okay, so no fracture is appreciable here. But if you look closely, since there is a trauma here and there is some listhesis, if you try and look closely, this is the L4-5 facet joint, where the L4 facet is behind L5 facet. But if you look closely, the L5 facet is here and the S1 facet is going here, which is more clearly visible on a CT scan. But if you look retrospectively, you can see on the X-ray. And this was the MRI, which showed a significant amount of disc disruption, as you very nicely could appreciate and tell us that there is increase in the disc space. That's because the disc is completely disrupted here. Okay, so this is a traumatic kind of spondylolisthesis. So this is another case. A 30-year-old software professional with severe back pain.
So sorry, I have a question in my last case. So in the last case, the listhesis was because of the dislocation of the inferior facet of the L5 over the superior facet of S1.
Yeah. So it's I think it's a combined, it's a global injury where you can see that there is disruption of complete disruption of the disc space. You can see the disc here. It is significantly edematous. And look at this cut. Can you see?
Yes, sir. Yes, sir.
This facet should have been here.
Yes, sir.
It has gone in front. And this
Yes,
is called as a naked facet sign. When we study the thoracolumbar trauma, whenever we have a class on that, we will discuss this. This is called as a naked facet sign, where one facet has become naked because its companion is gone because of dislocation. Okay, so there is a global injury of both the anterior and the posterior part of the spine.
Yes, sir. Thank you, sir.
Yeah. So let's discuss this one then.
Can someone from Maulana Azad Medical College volunteer for this, sir? आपके कोई residents है?
So is Nagendra here? I'll have to look at the list of participants. Nagendra is here online.
Is Nagendra here? Abhilash, Abhishek, are you all here?
Shashank is from MAMC or some.
I mean, there are actually residents from 3 medical colleges, so it gets really confusing. So anyway, Varun, would you want to take this?
Sir, this looks like a high dysplastic type of spondylolisthesis.
Okay, Varun, very good. But one tip from an examiner to a student: never give the complete answer in one go.
Yes, sir.
Even if
Sir,
you know, allow the examiner to ask questions from you.
Yes, sir. So the L5 vertebra has that trapezoidal shape, and you can see the end plate is and even of the vertical shape of the sacrum.
Yeah, very, very, very nicely told. So it's a high dysplastic spondylolisthesis. That's what I wanted to ask. If somebody would have answered it's a lytic variety, the next question could have been classified by Marchetti and Bartolozzi classification. So you can see here that the L5 body is trapezoidal. What are the other features, Varun?
Sir, the vertical sacrum is there.
Yes, the sacrum is vertical and
sir, the end plates are they are not, this space is reduced and the end plates are
the sacral end plate has become dome shaped.
Yes, sir. Dome shape.
These are all features of a high dysplastic variety of listhesis.
Yes, sir.
Okay.
Don't forget the mild degree of local kyphosis also. Okay.
Yes, sir. Yes, sir.
And this is the whole spine standing X-ray of the same patient, where you can see that the C7 plumb line, the faint blue line, which is in the lateral view, is not passing in through the posterior corner of S1. So there is a positive sagittal balance. Okay. Nagendra is there online. Nagendra, can you comment on this X-ray if you are present online?
Is Batsal here? Batsal, Abhilash, Abhishek, Gopal Yadav, Suraj, Nupam. It's only Tarini and Varun who are answering. I think they are the ones who are paying attention. Anyway, where are the others? Please, someone volunteer for this one.
Sir, there is a anterolisthesis of L5 over S1 with Pass Defect with loss of disc space between L5 and S1, sir.
Yeah. So it is a which type? Which type of spondylolisthesis?
So it is lytic.
It's a lytic variety of spondylolisthesis. Okay. Good. So this is again a lytic variety of spondylolisthesis where we can see features of high dysplasia, a trapezoidal L5 body, and a vertical sacrum. Okay. So in this X-ray, I think by now everybody is able to classify the amount of slip and the type of listhesis. But can somebody tell me some important finding or peculiar finding which is seen on the AP view here? Any volunteers?
Sir, is there a defect in the S1 lamina? So I'm not sure, but
No. Okay. So I will draw that finding for you people.
yes.
So is it a inverted Napoleon hat sign?
Yes, this is an inverted Napoleon hat sign, which is seen in a high-grade spondylolisthesis or a spondyloptosis on an AP view. So this oval-shaped structure of the hat is found by the L5 body, which is slipped forward, and these are the transverse process of the L5, which is called as an inverted Napoleon hat sign. Okay. So I think this is the last X-ray. I have put it for one particular reason. So let's see if anybody can pick up the positive findings here. So any volunteers? What are the positive findings? She obviously has spondylolisthesis, but what type of spondylolisthesis is it?
Varun, Tarani.
Sir, it's a low dysplastic type of spondylolisthesis.
Okay, so is it degenerative type or?
Sir, it's a radiologically, sir, it looks like a degenerative type.
Okay, what level?
So L5 over S1.
Okay. So this patient X-ray at the first look, if you see, has an L5 S1 spondylolisthesis. So there is a flexion view also. Have a look at that.
Yes, sir.
Tarani.
Is there mild L4, L5 spondylolisthesis also?
Yes, sir. Yes, sir.
So this is a two-level listhesis. There's an L4, L5 listhesis as well as an L5 S1 listhesis. Okay, so it's very important to recognize this and very easy to miss this. So our eyes are only get fixed on the L5 S1, but they can be concomitant listhesis at two levels also. And now this is debatable whether we need to fuse all of them or not fuse or manage them. But whenever you are planning surgical management for this patient, this consideration has to be kept in mind whether you have to address both or address one. Okay.
Okay, sir.
Look at the adjacent levels as well. So I think we are finished with today's agenda of grading the class spondylolisthesis and understanding various types and how to identify them. If there are any questions from any of the students, we can take them now.
Sir, I have one question.
Yes, Prashant.
Sir, since these are both of them are etiological based classifications, would they in any way affect our management, or are they only for just classifying the etiology?
No, Prashant, obviously any classification systems, they have a purpose, and one of the various purposes, and one of the purposes to guide us in the management. They do certainly have a role in guiding us management, because the behavior of each type of listhesis is completely different. So as I told you, degenerative listhesis, they have some sort of, they're not as unstable as lytic listhesis. So in those kind of cases, there are a subset of patients who may not require infusion and require only decompression. And even if requiring fusion, then they may not require a very aggressive interbody fusion. A posterolateral fusion may be enough. While in lytic listhesis, they frequently require stabilization in the form of pedicle screws and instrumented fusion. And even in instrumented fusion group, they respond better with interbody fusion group as compared to posterolateral fusion. So that's why it's very important to identify the kind of listhesis, because their natural history, progression, biomechanics is significantly different from each other.
Yes, thank you, sir.
Also, sir, I have one question, like which I want you to address these guys. Whenever you have these lytic kind of listhesis, can you just diagrammatically represent that picture where you can actually see the exiting root getting compressed, like for all our viewers, because that is the actual root where you have foraminal kind of stenosis in a lytic or a high grade slip.
Yeah, so I'll just go back to that spine model. I think we can understand on this. So this is the model of the spine, and how do the nerve roots they exit? So we all know the nerve roots exit through these foramina. So this is a foramen through which the nerve root will exit. Okay. So if this is the L4 vertebra, if this is L5, the root which will come from here is the L4 nerve root. Okay. So where does the compression occur in each kind of listhesis? So that depends on, again, the listhesis that we are dealing with. In isthmic variety, lytic listhesis or elongated parts, the problem is in the isthmus, which is this part. We commonly see the defect here. Okay. The root which is coming through here is one root. The next root is passing like this. Okay. So the root which is coming here is L5. The root which is coming here is L4. So if we have a lytic spondylolisthesis where the problem is here, which nerve root do you expect to be affected? The L4 nerve root, which is the exiting root here. The traversing root, which is the L5 root, is usually not affected in a lytic or isthmic kind of listhesis. There is a foraminal or a far lateral compression in lytic listhesis. Understood? And what happens in a degenerative listhesis? Again, let's draw the two nerve roots. This is the L4 nerve root and this is the L5. In degenerative listhesis, where are the problems occurring? Occurring at the facet joints. Then the problems are occurring in the disc space. The disc is coming out. The flavum is getting hypertrophied here, both sides. So it is a traversing root which is getting affected more as compared to the exiting root. Okay, so this kind of understanding you need to have, because whenever you are surgically decompressing, you have to differentiate what kind of listhesis you are dealing with and which nerve root you have to decompress. Okay. Thank you, Dr. Rohan, for bringing up this query, because it's very important for surgeons and residents to understand this concept.
Thank you so much, sir. Are there any more questions from anyone? So I think that brings us to the end of this first part of spondylolisthesis. I really thank you again, Tarun sir, for taking your time out and really starting from the very basic of this interesting chapter on spondylolisthesis. I also thank OrthoTV and Neeraj sir for giving us the opportunity and allowing us to take this initiative of the series, which is going to be every Wednesday now. So yeah, and I thank you all residents, and I hope that you all participate voluntarily next time. And thank you again, sir.
Thank you, everybody. Thank you, Dr. Rohan. Thank you to all the residents for making it an interactive session.
Thank you. Okay. Thank you.